The next topic under late pregnancy complications is third trimester bleeding. Now this is a commonly tested step 2 subject, and the key points will be the differences in the differential diagnosis and workup of third trimester bleeding as opposed to the first trimester bleeding, which we've already gone over. So we can go through the differential diagnosis by evaluating all the areas which can bleed during the third trimester of pregnancy. On the vulva, there can be trauma or varicose veins. The vagina can have lacerations. The cervix can have polyps, infections, or cancer. And the uterus can have a uterine rupture, placenta previa, vasa previa, or placental abruption. Again, the differential diagnosis is broad, and we're going to focus on the uterine causes of third trimester bleeding, as these are the most testable areas on the Step 2 exam.
The first on the differential is placenta previa, which is the abnormal implantation of the placenta over or very near the cervical os, and accounts for 20% of prenatal hemorrhages.
Risk factors include previous uterine scar. The most common is, of course, the cesarean section scar, multiple gestations, as we discussed earlier, and previous placenta previa. So let's review a case which demonstrates some very important aspects of placenta previa. A woman presents at about 32 weeks, stating that she woke up with a large amount of bleeding, and they want to know what the next step in management should be. And so this question just gets at the initial workup and diagnosis for third trimester bleeding. They give us the options here of a digital vaginal exam, transabdominal exam, vaginal delivery, cesarean delivery, or transvaginal ultrasound. The answer here is a transabdominal ultrasound. When you have somebody that presents with third trimester vaginal bleeding, you always have to be thinking about a previa, and you never do a digital exam without knowing where the placenta is. There's no more information that indicates the need for an emergent delivery at present time. And we would often do the transabdominal ultrasound first because the transabdominal ultrasound is safer than the transvaginal. Similar to sticking your fingers in the vagina, you don't want to stick a vaginal probe into the vagina without knowing where the placenta is. So if we did an ultrasound transabdominally of our lady who presented to the emergency department, we may see this. The bladder is indicated anteriorly, and just behind the bladder is the uterus, and the placenta is indicated, and we see the placenta goes across the entirety of the cervix. And this would be what we would see with a complete placenta previa. So the take-home message from our case and the key on your Step 2 exam is that digital vaginal exams are contraindicated while working up third trimester vaginal bleeding if you don't know where the placenta is. Sticking your fingers in a placenta previa can cause separation between the placenta and uterus and truly severe hemorrhage, which can be life-threatening. So let's delve a little bit more into the previa, briefly talking about presentation and diagnosis. So the buzzword on the Step 2 exam in your STEM is going to be painless vaginal bleeding. And this is going to be different from painful vaginal bleeding, which makes you think of something very different. We'll discuss that in a minute. Usually, previas will present after 28 weeks gestation. Again, the diagnosis is made by transabdominal ultrasound looking for the placental location. You may see an answer stem which may read translabial ultrasound, which is also an acceptable answer as it's as safe as a transabdominal ultrasound. So there is a number of different types of placenta previa, all of which can be diagnosed on ultrasound, and the definitions vary based upon how much of the placenta is covering the os or how far away the placenta is from the cervical os. It may be beneficial just to go ahead and memorize a couple of these definitions in the table here. A complete previa is, as you would expect, a placenta that completely covers the cervical os. This is as opposed to a partial previa, where there's only a partial covering of the cervical os.
A marginal placenta previa, where the edge of the placenta is at the margin of the internal cervical os.
Some other key definitions is a vasa previa. Now, the vasa previa are fetal vessels which present over the cervical os, and these can be very dangerous. A low-lying placenta is a placenta that's implanted in the lower segment of the uterus but does not cover any portion of the internal cervical os. And these can be clinically important, but usually they'll resolve as the pregnancy goes on and can simply be followed by an ultrasound later in the pregnancy. In order to better illustrate the different types of placenta previa, we see that the complete previa covers all of the os, partial only half of the os, marginal comes down to the edge of the os, and the low-lying placenta is in the lower uterine segment. Here we have an illustration of a vasa previa. Note that the fetal vessels are coming down near the internal os, and again we can see how this can cause some severe fetal hemorrhage if those vessels are disrupted at the time of rupture of membranes or during labor. So there are a few things that we would do for patients who have placenta previas. The first and very important is strict pelvic rest, and this includes intercourse. We don't want anything in the vagina that could disrupt that placenta. Next, we need to prepare for life-threatening bleeding by getting a type-in screen, CBC, and sometimes coagulation factors. There are a number of fetal considerations. So if the fetus is preterm or before 34 weeks gestation, we would consider giving betamethasone to mature the fetal lungs. And delivery. So delivery route is going to be by cesarean section. And the reasons for delivery will be labor, so cervical dilation along with contractions and bleeding, severe hemorrhage, which can't be stopped, or fetal distress as seen on the fetal monitoring indicating hypovolemia of the fetus. Now, if the patient makes it to 36 to 38 weeks gestation, an indicated cesarean section is performed at that time regardless of bleeding status.
So we're going to move on to another cause of third trimester bleeding, that of abnormal placental attachment. There are different types of abnormal attachment which are diagnosed based upon depth of villi growth into the uterine wall. Placenta accreta refers to an abnormal placental implantation in which the anchoring placental villi attach to the myometrium rather than being contained by decidual cells. This results in a placenta that is abnormally adherent to the uterus. A placenta increta is when chorionic villi invade into the myometrium. A placenta percreta is where the chorionic villi penetrate to or through the uterine serosa and may invade surrounding organs, such as the bladder or the bowel.
Often, the placental invasion cannot be seen on a prenatal ultrasound, but can result in significant amounts of postpartum hemorrhage, which is often how these are diagnosed. Patients are typically asymptomatic while they're pregnant unless the invasion involves the bladder or the rectum, in which case hematuria or rectal bleeding can occur. A treatment in this case may require cesarean hysterectomy, where a cesarean section is formed to deliver the baby, and then the uterus is removed afterwards. This diagram better illustrates the different types of abnormal placental growth. In the top left, we have a normal or decidual reaction. Here we see an accreta, which occurs in 75 to 78% of the cases, a placenta increta growing into the myometrium in 17% of the cases, and a placenta percreta growing all the way through to the serosa. There are several risk factors for placenta accreta. One of the most common is placenta previa. Another is prior uterine scars, and again, both of these go hand in hand. Cesarean section is the most common cause of uterine scars, and with increasing rates of cesarean section, we're seeing an increasing rate of placenta previa and placenta accreta. Moving on to the next cause of third trimester bleeding, placental abruption. Differentiating between placental abruption and placenta previa will be key on the Step 2 exam. So a placental abruption is an abnormal, premature separation of the placenta from the uterus. The effects can vary. A complete placental abruption can result in life-threatening bleeding, premature delivery, uterine tetany, DIC, and hypovolemic shock, whereas a partial abruption may result in only minor bleeding or no clinical signs or symptoms at all. The primary etiology is unknown. However, there are a number of risk factors. These include maternal hypertension in the form of chronic hypertension, preeclampsia or eclampsia, prior placental abruption, tobacco use or cocaine use, or trauma, commonly manifested after a motor vehicle accident. The clinical presentation starts with vaginal bleeding, since we're in the third trimester of bleeding section, and then the key part, severe abdominal pain, and this is opposed to the placenta previa, which we can see painless vaginal bleeding. Oftentimes the bleeding will cause contractions to occur, and on fetal monitoring we can see evidence of fetal distress. Now there is a caveat to this presentation. A concealed abruption occurs when there's bleeding without any evidence of external bleeding. So in other words, the bleeding occurs behind the placenta and doesn't come out through the cervix. So oftentimes, placental abruption is a clinical diagnosis, since as opposed to a placenta previa, we can't always see it on the ultrasound. So we rely on evidence of contractions, vaginal bleeding, and potentially fetal distress as manifested on this non-stress test where we see late decelerations. So as we mentioned, the diagnosis can possibly be made by transabdominal ultrasound, although this is not terribly reliable, or based on the clinical scenario. Again, key to remember for the Step 2 exam, placenta previa presents as painless vaginal bleeding, placenta abruption as painful vaginal bleeding. Here we see how a placental abruption can be diagnosed on ultrasound. Behind the placenta, we see the accumulation of a large amount of blood clot. Ultrasound is only about 40% sensitive, and this is in that trauma setting where the pretest probability of an abruption is high. So we briefly mentioned the different types of placental abruption, and we'll delve into them a little bit more in this table. So a concealed abruption is blood within the uterine cavity, and the placenta in these cases are more likely to become completely detached as that hematoma swells and separates the placenta from the uterine wall. Complications, serious ones, can involve DIC, tetany, fetal hypoxia, fetal death, Sheehan syndrome as a result of severe hemorrhage resulting in postpartum hypopituitarism. An external placental abruption manifests as blood coming through the cervix, and the placenta in this case is more likely to be partially detached as the pressure is decompressed through the cervix. Complications in these cases are usually smaller with minimal complications. When asked to come up with a delivery plan on the Step 2 exam, it will typically be determined by the clinical circumstances. A cesarean delivery is indicated with uncontrollable hemorrhage or evidence of fetal distress on a non-stress test. Vaginal deliveries can be undertaken when the placental separation is limited, the fetal heart tracing is reassuring, or there is fetal death prior to presentation. An ever-present reminder of a commonly tested Step 2 topic. Moms who are Rh negative need to be given anti-DRH immunoglobulin when they present with a placental abruption. The medication is most effective when given within 72 hours of the onset of bleeding in order to prevent alloimmunization.